Well, hello, everybody, and welcome. Welcome to the Live with Leslie show. And I'm so happy to have you here with me today. And today, oh my gosh, I'm really just so looking forward to my conversation with Dr. Jessica Whelan. And I'm going to do a more formal intro here in just a minute. But to start, just to kind of give you an idea in terms of what we're going to be chatting about today, if you yourself happen to be struggling with infertility, or perhaps you are working with clients that are experiencing infertility, and maybe either yourself or your clients, they don't want to go into the whole IVF world, you are definitely in the right place today, because today we're going to be talking about really why infertility is a symptom of an underlying root cause, right? So, really looking forward to digging into this very interesting topic. So, welcome again. Hi, everybody. My name is Lesli Bitel, and I'm a practice growth expert, specifically working with health practitioners who want to attract more clients, sell more programs, ultimately grow a joyful and profitable practice while integrating multiple streams of revenue into their business models. And today we are talking to Dr. Jessica Whelan. Hey, Dr. Jessica, how are you today?
Hello, everyone. Thanks for having me. I'm doing well.
So happy to have you. So I'm going to go ahead and just kind of give you an overview of Dr. Jessica's background. So Dr. Jessica happens to be a naturopathic doctor, a women's health expert specializing in helping women who are struggling with hormonal and menstrual cycle issues, including fatigue, brain fog, insomnia, anxiety, mood swings, painful or unpredictable periods, and of course, infertility. And so, what she does is she helps women naturally restore hormonal balance to have accessible, predictable, pain free periods, deeper sleep, more energy, better moods, optimal fertility, and ultimately experience a more vibrant, thriving life with healthier relationships. And Dr. Whelan also helps couples understand their shared fertility to precisely and naturally avoid or achieve pregnancy while growing in authentic intimacy. So I have had the pleasure of working with Dr. Whelan over the past several months, have gotten to kind of know her approach and her, really just kind of gotten a taste of her wisdom. And let me tell you, you guys are in for a really big treat. So welcome, Jessica.
Thank you.
Delighted to have you. So let's go ahead and jump in because this is such a pertinent topic. And it's just so interesting how, at least from my perspective, it really has evolved, right? Like coming from, I guess, more of kind of the more, I don't know, traditional knowledge base. I got to be honest, I wasn't aware until more recently that lifestyle and, nutrition, inflammation, I really honestly didn't make that connection with infertility, nor did I make that connection with some of the other, diagnoses that you work with, right? Endometriosis and, painful periods and that kind of a thing. So this is just really fascinating, from a personal perspective, and it's exciting to hear that there are alternative mechanisms and just alternative treatment modalities, right? Other than, like we said, having to resort to IVF. So, all right, so let's dig in. Let's start by talking about, I know, an area that's near and dear to your heart, and that is the Creighton model. Okay.
Yes.
Lots of people, I honestly was not familiar with this until we started working together. And so I'd love for you to just kind of give our audience just a little bit of an overview of, what is it? How does it work? And how do we integrate the Creighton model into naturopathic medicine?
Yeah. So I'm so excited to share about this, trying to get the word out. It is, for the first time really in the history of women's health, ability that we have to combine the ability to naturally achieve or avoid pregnancy, identifying our fertility precisely with comprehensive women's health care. And so the Creighton model, I learned it actually after medical school. It's based in Omaha, Nebraska, and it's named that because the early research was done at Creighton University. And so it started in the 1970s by Dr. Thomas Hilgers. He's an OBGYN, and it really built upon, research that was happening decades ago that he put together, validated, and then has continued and is still continuing to this day. And so what I love about it is it's all about finding the underlying cause of women's health issues. And so, with the onset of like the pill and IVF, the incentive for science to research our procreative health is there's not really much of an incentive, to be honest. They study a lot of our like bleeding abnormalities, but there's so much that goes on the rest of the cycle. And so this is what the Creighton model is all about, is what else is going on all those other weeks of our cycle. And so the reason it goes really well with naturopathic medicine is the philosophy is the same. We're trying to find that underlying cause, remove obstacles to our health, and then support the body with what it needs to really heal. So like really trusting in the healing wisdom of the body.
Okay. So, so you had to it's a whole separate certification, if I'm understanding, right?
It is, yeah. And so just so the audience is aware, so the Creighton model fertility care system, we have practitioners. So these are people that are trained a really rigorous 13-month program to teach clients how to chart their cycle. Without the client charting, we cannot do our job as the doctor. And then we have medical consultants, which do the medical side, which you might hear that word NAPRO technology. It stands for natural procreative technology. And then we also have surgeons that are trained in specialized surgical approaches that also are about, it's like restorative medicine.
Oh, fascinating. Okay, so you basically, on top of your, naturopathic training, medical school, you added another 13 months of the specialized training to your area of expertise, right?
Honestly, it's changed my personal health. It's changed my personal life, just to be that connected with my own body and my fertility. It's things that even as a naturopathic doctor, we didn't learn the full extent of in school.
Okay.
But at the same time, it goes really well together. So it's just brought everything together.
Oh, that's so cool. I know you're super passionate about helping people with the tools that you've acquired through this process. So how would you say, how is the management of infertility different with the Creighton model versus other, maybe fertility clinics and, kind of more of the typical approaches in, I guess, mainstream medicine?
That's a really good question. So again, we find the underlying cause. So we can't do our job without the client couple charting. So we usually require about 2 months of charting so we can really see what's going on with the hormones. After that, we're like we said at the beginning, infertility is just a symptom of something deeper. And so shockingly enough, a really common but simple cause of the experience of infertility is limited cervical mucus. Sometimes this is a quick fix, honestly. Like we have protocols that can help support the receptors in the cervix. Sometimes they're damaged through like a history of having an IUD, for example. Other times it's more complicated. So like limited cervical mucus could be a sign of endometriosis. We think of endometriosis as something like really painful period, super obvious. But interestingly, asymptomatic endo is also pretty common cause of the experience of infertility. And a woman wouldn't really know because she's not having, pain, but she might have limited mucus cycles. So this is really important to treat because they've also correlated endometriosis with ectopic pregnancy. And so we don't have enough, the cervical mucus works not only in our cervix to help sperm transport, but it also helps the cilia in our fallopian tubes. To move the baby to implant in the uterus instead of the fallopian tubes. So just so many examples of that where we're looking for that underlying cause. There's so many biomarkers we can see from a woman's charting. A lot of times it's low progesterone could be an issue, which I think we're going to talk about a little bit later. But I just wanted to lean into the endometriosis just a little bit more, because this is a really common thing. And I want, the audience to be aware is the gold standard is surgery. And the thing is, though, when it's asymptomatic and a woman's not in pain, a lot of times it's not even evaluated for. And so they'll skip right to IVF, because the art of diagnostic laparoscopy is kind of being lost, to be honest, in the conventional world with NAPRO. We have, like I said, a world-class, it's robotic surgical technique. And they have found that about 50% of women with PCOS actually have asymptomatic endometriosis. And what it is those lesions, they secrete toxins that can prevent pregnancy or implantation. Now, while surgery is, like, I always say, it's the tip of the iceberg, like it is the gold standard, but there's so much else causing it. And so even after surgery, it can grow back. And so you really need to be treating the underlying causes. A lot of it is immune dysfunction. So it's kind of considered an autoimmune disease, and also estrogen imbalance. And so with like naturopathic medicine, as well as NAPRO, I work with, leveraging the power of food as medicine, detoxing, the endocrine disruptors, helping the nervous system. But then we also use bioidentical progesterone and low dose naltrexone. And so those can be really effective in mild cases to shrink those lesions and reduce the need for surgery. And then if a woman does get surgery, it's going to help, help her stay healthy. So just one example.
Wow. So are you, gosh, I'm hearing a little feedback. Can you hear that on your end, or is it maybe just my end? Hopefully. Okay. Great. As long as it's just me. Okay. Well, I mean, gosh, I'm kind of floored by that, because I honestly, I just wasn't aware that there was any other option besides just getting surgery, right? Kind of going right in and having surgery to take care of that. So it's actually really good news, and interesting that you're incorporating LDN, low dose naltrexone, into the mix. I'd love to hear from our audience. Are you guys familiar with LDN? Have you heard of it?
Leslie loves it.
I want to go on my soapbox about LDN. No, not really. It's just, it amazes me all the different, all the different areas in which it's helpful, right?
Yeah.
I had no idea that it was helpful with women's health, and specifically with any of the infertility diagnoses. So yeah, I would love to hear from our audience if you guys are familiar with LDN. If you have any experience, maybe you yourself taking it, or maybe you're a dietitian who has noticed that some of your clients or patients are on it. All right. So in terms of, I wanted to ask you, do you have any, statistical kind of information that you can share?
Yeah, another great question. So again, Dr. Hilgers over at the St. Paul VI Institute, he does so much research. He loves statistics. They've actually found that the Creighton model fertility care system combined with NAPRO is up to 3 times more effective than IVF, or artificial reproductive technologies. And so this is a shocking statistic. 20 to 40% of couples that were diagnosed as infertile are able to achieve pregnancy simply by charting their cycles. And so this is simply understanding their days of fertility and knowing when to time intercourse. That's kind of heartbreaking to me, but also fascinating. And then up to 80% of couples that are diagnosed as infertile are actually able to achieve pregnancy with combined cooperative medical care. So that's that natural procreative technology. So that statistic is going to vary depending, again, on the underlying cause. But, women feel better in the process. There's a lot of healing that goes on, not just physically, but emotionally, spiritually. So, because they're getting the underlying cause treated, right?
Absolutely. Okay, I just want to put this. This is from Jessica. Welcome, Jessica. So, would you be willing, Jessica, just to kind of give us an overview in terms of LDN, and just because my guess is that maybe a lot of our audience has maybe never heard of it.
Oh yeah. So low dose naltrexone, it's used for alcohol dependency at the normal typical dose at 50 milligrams, available over the counter. But they found that low dose, sometimes as low as like a half a milligram, can be really, really effective for a wide variety of situations. In medical school, we called it snake oil because it really does. It's just so helpful for so many things. But since it works on that opioid receptor, it can help modulate our endorphins, which, from a women's healthcare approach, we actually use it for PMS protocols.
Yep.
But it also modulates our immune system. So it can be effective for autoimmune diseases such as Hashimoto's thyroiditis, endometriosis, for example, sometimes like ulcerative colitis, that type of thing.
Yep. So it's LDN. And guys, anyone that's interested in learning more, I would go to the ldnfoundation.org. I'm pretty sure. Let's see if I spelled that right. I think so. Go to the ldnfoundation.org. And this is an organization in the UK. And they are doing all kinds of really cool research on this compound. And it's a really old drug, right? A very, very old, I mean, gosh, it's been around forever, right? So, but they just keep finding all of these new uses for it. So, and just a little bit of background on me. I became aware of it from a personal standpoint when I was really struggling with mold exposure, and lived in a moldy environment without knowing, and so really was kind of struggling with immune dysfunction. And so I worked with a functional medicine doc, and he prescribed that. And it really, of course, you have to get out of the mold before you really see great benefit. But anyway, it's a great immune modulator for the most part. And it also has some other pretty incredible uses. I mean, I know there's studies with depression, anxiety, even cancer, chronic pain, neurological, or I should say, nerve pain, right?
Mm-hmm.
In the extremities, that kind of thing. So anyway, really just kind of fascinating. So so very exciting that you guys are integrating, and you learn this in medical school, integrating that into this fertility model.
Mm-hmm.
Okay. So, all right. So we talked a little bit about those statistics, which pretty mind blowing, right? Who would have known?
Yeah. And just for interest's sake, the Creighton model, I work with people who are using it to avoid pregnancy sometimes too. And so that's 99.5% effective, and 96.8% effective for avoiding pregnancy naturally, which is about the same statistic as the oral contraceptive, and way better for our health, right?
Way better.
Not just our health as a woman and like avoiding side effects, but also for, again, that marital intimacy. We're really empowering couples with this new shared language that they've never had access to before, to communicate about the most powerful force that they share, in the universe, which is their co-creative ability. And so it's just it's really interesting. It's hard to put into words how healing it can be for marriages, for relationships. We can't separate our body, mind, soul, spirit. So.
And what practice would you say you integrate the Creighton model?
Oh, that's a great question. I try to get everyone to do it. Granted, I can definitely help people with naturopathic medicine without Creighton, but it just adds so much. I'm able to accurately time their progesterone labs. We can accurately dose progesterone, which I do not feel comfortable doing unless they're charting with the system. I think we're going to talk about that a little bit later. Like, historically, it's one of the most challenging things for doctors is to know when women ovulate, because a lot of women don't even know. And this is the most precise way to time ovulation too. So I don't know, I'd say maybe 75% of my clients also are charting.
Okay.
Yeah.
So, all right, let's dig into how the Creighton model of fertility tracking, how is it different than, you know, for example, temperature take? I mean, that's what I would be most familiar with is kind of that traditional, monitoring temperature, uh,
Okay.
and as well as the ovulation predictor kits, right? Which are over the counter, really easy to access. So, how would you, I guess, compare
Yeah. Yeah.
to all the other options available?
It's like such a great question too. Yeah. So I like kind of geeked out on my body in medical school and did all the things just to understand my own self.
Yeah.
Um, but then we learn about this more in detail with the Creighton. So temperature is interesting. That can be, some people like it. It can be pretty tedious. I know they have some really good like programs out there like the Lady Comp or Daisy now, which are pretty cool. So progesterone rises after we ovulate because progesterone is thermogenic, right? So it's a good way to see like when our infertile time starts. But if you're trying to conceive pregnancy, it's not helpful. We really can't base, one cycle on like something that happened a cycle ago because every cycle is different. So we only know when we're infertile with temperature because we already ovulated. Ovulation's over and done with. Um, and it doesn't really tell us even like we might know if we ovulated, but we don't know if we even ovulated well. With the Creighton model, I detected 6 types of ovulation defects. So the question's not just are we ovulating, but are we ovulating well even? So that's with the temperature. Ovulation predictor kits, some of them measure LH, which is a hormone that surges and peaks right before ovulation. Some of them have estrogen and LH. Some people like these, so they'll surge about 36 hours before ovulation, so women can time intercourse. However, for a lot of women like myself that have struggled with like polycystic ovarian syndrome, hormone imbalance, that LH is typically elevated above FSH quite often. And so for me, like it was always saying I was like about to ovulate. And at first I was excited. So I'm like, cool, my body's like, we're
Right.
I do have a lot of clients that come to me that are already charting with like apps. There's a lot of apps out there now. And so it's great. I always affirm them. It's so good to like care about your body and to, our menstrual cycle is a vital sign. It's just as important as our blood pressure. So that's great. But again, like no algorithm based app can ever know you as well as you know you. And so the Creighton model teaches us to listen to our body every single day, and it changes every single day. And so instead of like predicting it with the algorithm, we're just learning it live, like real time. And so I teach women, how to identify what's called the double peak, which happens with a stress cycle. And so it's like your body starts to make that cervical mucus. It looks peak type. And then when we're under stressful conditions, sometimes it just piddles out, and it's a protective mechanism so we don't conceive under a stressful time. So it could be a like happy stress, negative stress. And every woman has a different set point. Like I like react really sensitively to stress. Other women can go through a war and still ovulate. So it just teaches us how to listen to our own bodies really with the Creighton model.
So interesting. So I had a question for you. I think I heard you say that, okay, yeah, questioning, are you ovulating well? What does that mean? Like,
Yeah.
I kind of thought it was either you did or you didn't, right? Like yes or no. But you're
Mm-hmm.
saying there's degrees of, well, like quality ovulation, I guess.
Yeah, there are.
Tell me a little bit about that.
Well, with the Creighton model, they've been able to document more spontaneous ovulations in the world than any other program in the world, and they can do that because women are charting with the system. They know when they're approaching ovulation, so the doctors can do serial ultrasounds.
Okay.
And this is how they've been able to research and find ovulation defects, and they've studied 6 different types. So some examples would be like an immature follicle where it doesn't grow to the complete size. Some are what's called a incomplete rupture. Sometimes it doesn't have what's called the cumulus oophoris, which is like these supportive nourishing cells that support the egg. What else? Sometimes this is really interesting is sometimes women have what's called a luteinized unruptured follicle. And so the body will still make the corpus luteum, which makes progesterone. So their temperature's going up, but they didn't ovulate, which is really interesting. And sometimes that can even happen in the context of a regular cycle. So they get their period at expected time, they think they ovulated. And so, it's interesting, like more cases of infertility happen in women with regular cycles.
Wow.
And so they're even more unsuspecting because they are like, I have perfect clockwork cycles. Why am I struggling? And then sometimes it's the PCOS women that have those irregular, crazy cycles that are sometimes easier cases, to be honest, because we can reverse a lot of the symptoms more easily.
Okay. I mean, kind of from a high level, it makes sense. We have a great question here. And I wondered if you could speak to this. What about if you have implantation issues?
Yeah, that's a fantastic question. So like I mentioned earlier, with the Creighton model in Omaha, Nebraska, they have a fellowship program for OBGYNs, and it teaches high level, surgical perinatal techniques. And so sometimes women do have, adhesions from prior surgeries that are impacting implantation. Sometimes it's like endometrial polyps, things like that. And so with this robotic surgery technique, they're able to go in there, correct some of these structural issues, and it's nearly 100% adhesion-free surgery. So that's really exciting.
Wow.
Mm-hmm.
Okay. Awesome. Okay. So, so what would you say are some of the critical risk factors that we need to identify prior to conceiving in order to ensure a healthy pregnancy?
Mm-hmm.
Right?
Yeah, this
So,
is a great question. And it's exciting because when couples are charting with me before they try to conceive, I can identify some of these risk factors and hopefully prevent a miscarriage due to low progesterone, for example. So like if I see a short, what we call post-peak phase, it's essentially like the luteal phase, less than 9 days, that's an elevated risk of miscarriage. The body doesn't have enough progesterone to support a pregnancy. So it might implant, right, but not maintain. Sometimes premenstrual spotting, if it's more than 3 days before the true flow, that's also a sign of low progesterone.
okay.
Tail end brown bleeding. So even more than 1 day of brown spotting at the end of your period can also be a sign of low progesterone, which would also be a risk factor for miscarriage.
Oh.
So if we're able to identify these things ahead of time and treat them, then we can hopefully prevent a miscarriage due to that reason.
Okay.
I even do a PMS screening with all my patients. So PMS, it's a lot of people think we just have to live with it as being women, but it is clinically significant if they have even one of these symptoms more than 3 days before their period. And so the screening is breast tenderness, bloating, weight gain, carbohydrate cravings, insomnia, fatigue, crying easily, depression, headache, or irritability. So even if they just have one of those more than 3 days before the period, it's clinically significant, typically that hormone imbalance again. So that they deserve to have it treated for quality of life. But also, PMS is a risk factor for miscarriage and also for postpartum depression. So
Okay.
important to treat it now. We do have special protocols for postpartum depression, but if we can, manage it before they even conceive, that's really preventative care.
Right. Oh, obviously that could be devastating.
Yeah.
To the newborn as well, obviously.
Yeah. It's really sad, and it's such an under kind of evaluated and treated condition.
Absolutely. Oh my gosh. So like in your practice then, would you say the majority of your patients are trying to get pregnant? Like what would you say, a little bit of a composition of the types of clients and patients you're working with?
Yeah, that's a great question. So we did this topic because it's super interesting, but I would say no, I would say maybe a quarter, 25%. So I have a pretty diverse patient range. I actually work with teenagers. I have a client that's 13 years old and she's learning this for her health. She had recurrent ovarian cysts and she wanted alternatives to the pill. I've worked with 16-year-olds with painful periods, single women that are just trying to take care of their health. I do work with some couples that are using the system to avoid pregnancy. And then I do work with couples in my preconception program as well.
Amazing.
It's kind of diverse, but it's
I love it.
It's all good.
I love it. Okay, great. All right. Well, as we kind of start to wrap up, first of all, do we have any questions from our audience? We've had a few come in, but any additional questions that you guys, okay, let's see. Okay. Do you work with a lot of people with PCOS?
Yeah. So PCOS, I have a particular heart for it because I've struggled with it my whole life, and I didn't really get appropriate care until I was really going through naturopathic medical school myself in my 30s. So I'm 39 now, and I'm healthier than I've ever been. But it's exciting because you can support them so much with nutrition, lifestyle, and then when I can get them charting and use NAPRO, it's just it's such a so in many cases, a really reversible symptom picture.
Absolutely. Okay, great. All right. So where can we send people to find out more about your work?
Yeah, so I have a website, drwhelan.com, and so it's WHELAN.
Okay, I'll put that in the comments.
Yeah, intake form right on the website to reach out. Thank you, Leslie.
Yeah, so reach out if you want to connect with Dr. Whelan. I would, assuming professionally or, as a patient.
Mm-hmm.
And yeah, go to her beautiful website. It's wonderful. It's a pretty new website. We're so excited about that.
Yeah.
Any kind of final words of wisdom that you want to share with our audience as we wrap things up for today?
Yeah, I guess your health matters, your fertility matters, and it's something I just never was told. Even if you're not trying to conceive, like your health matters, and so your fertility is not just about your reproductive system. It affects your mental health, your gut health, your bone, your heart health. It's your body, and it's how we connect ourselves, spiritually as well. And there was one more thing when you were asking about how this work varies from IVF clinics.
Yeah.
So yeah, from the physical health perspective, absolutely. But also when you look at like all those other levels of our health, so that psychological, emotional, that can really be hard on a marriage. And so this system just really, and how I work with clients, really upholds their fully human dignity, and really does not compartmentalize and just make us, our reproductive organs. So it does that, in many, many ways, but just a simple example could be something as subtle or simple as, the way we do a semen analysis is super ethical. I work with ReproSource, and they're able to collect during a normal act of intercourse and send it off instead of, in a way that's kind of dehumanizing to the man.
I love it.
Yeah.
Oh, so good. So good. All right. That's a great point. All right, guys. So as we start to wrap up today, I want to thank you all for joining. Thanks to all of you that joined us on the replay as well. I hope this was really helpful. I learned a ton as usual. And if you want to reach out, I've added Dr. Whelan's website. You can see it there on your screen, drwhelan.com. And I just want to thank you, Jessica, for spending time with us today, sharing your wisdom. Such a fascinating topic, truly. It's such an advancement. Let's see. Okay. Here we. So, is just okay. What? Yeah. We don't know who is that, Doctor.
No, that's so old.
Is it old? Okay.
I need to take it down.
Okay. Yeah. So it's drwhelan.com. And if for whatever reason you should be able to find it. If for whatever reason you have a hard time, just email me and I'll connect you. Oh, okay. So it looks great though. Okay. Hopefully that is resolved. I'll include my email as well, just in case you have any difficulty, and I'll make sure to be the connector. All right. So Leslie at lesliebitel.com. All right, guys. I hope you have a wonderful rest of your day, an awesome week. And I will look forward to reconnecting with you, same place, same time, next Thursday. All right, guys. Have a great day. And thanks again, Dr. Jessica. Really appreciate your time today. Bye for now, everybody.